So the question is, how do you safely commence transcutaneous pacing? The patient you're going to do this on will have a slow heart rate that is causing end organ symptoms from the resultant hypotension. Those end organ symptoms may be chest pain, confusion, shortness of breath, lightheadedness, or poor peripheral perfusion. Most often, we would do this temporizing measure on a person with symptomatic third-degree heart block. Less often, it would be other bradycardic rhythms like Mobitz type 2 or occasionally sinus node pathology. You are doing it as a temporizing measure in someone where atropine has not worked, and after starting it, you're going to take the patient for an urgent transvenous pacemaker. So, explain to the patient what's going to happen. Then give analgesia and sedation. Personally, I strongly prefer ketamine IV at a dose of around 0.5 to 1 milligram per kilogram. It works, and you don't get those pesky airways issues that narcotics and benzos bring. Now, attach the pads. They're color-coded, black or blue at the front, red at the back. Put the front one on the left anterior chest wall, where V2 and V3 would be. Put the other pad on the back between the lower part of the left scapula and the spine. The monitor I'm used to, the Zoll R series, has a built-in 3-lead ECG, so you don't need a separate one to read the patient's intrinsic rhythm. Next, put the monitor on pacer mode and choose a rate of 80 per minute. Then increase the output to 80 milliamps. This should get you electrical capture on the monitor almost all the time. If it doesn't, then increase the milliamps by 5 or so every few seconds until you get electrical capture. Check the patient now has a peripheral pulse and reasonable blood pressure from the newly increased heart rate. And whilst the patient's enjoying the IV ketamine, which you can top up as required, head off to the cath lab for a transvenous pacemaker. Done.